Hi, and welcome to episode 308 of the Untethered podcast. Today we have Dr. Kristina Wolf joining us. Dr. Wolf is a Cleveland native and a mom of two amazing little kids, Kaya and Leo. It was actually these two little humans that got her interested and involved in the world of sleep. What further intensified her desire to get involved in the disciplines of sleep and pain was her own struggles and healing journey after suffering with TMJ and sleep issues. She has a private practice dedicated to pain and sleep and is also a professor at her alma mater, Case Western Reserve University School of Dental Medicine, where she teaches the sciences including anatomy, physiology, and neuroscience. She received her Doctor of Dental Medicine, DMD, from CWRU, as well as a Master's of Science in Applied Anatomy. Her mentor, Dr. Stephen Olmos, has now brought her on board as the primary educator for TMJ and Sleep Therapy Center International, where she leads a mini residency program domestically. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie Vulcan. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Kristina, welcome to the podcast.
Hi, Hallie. How are you today?
I am good. I'm excited to have you here. So we're going to jump in. And before we do, I would just love for you to share with everybody a little bit about who you are and how you got into this airway space.
Yeah, so I am Dr. Kristina Wolf, and I have a TMJ and Sleep Therapy Center here in Cleveland, Ohio. I got into airway and everything, all of the facets of treating TMD and comorbid airway disorders because I had my own problems. And I'm sure, as most of your audience knows, and you know, then you look around at everybody you know, and you see it all over the place. You can't unsee it once you see it. So it's so prevalent. And so, of course, then I was seeing it within my own family, right? So my stepdad, who had AFib that couldn't get under control. And I said, you know, you're shaking the room, and I'm pretty sure you have sleep apnea. And of course, once we treat these things, those go away. My kids, both of my kids, who we found out had sleep apnea, and sleep breathing concerns that we had to treat in them as well. So unfortunately, as again, I'm sure most people know, when you kind of get into this and you start looking around and you start seeing, you also start to recognize that there's really nobody doing this or not enough people doing it. And so I said to myself, you know, if I was having this hard of a time finding somebody to treat myself, my kids, my family, all these other people that I'm seeing, there's just not enough of us out there. So that for me was a pretty quick changeover of I need to completely shift gears. I want to go completely out of doing any general dentistry, and I 100% want to treat TMD and sleep. And I was very fortunate enough to be introduced to Dr. Olmos and the TMJ and Sleep Therapy Centers, and you know, he mentored me and raised me up, right? And kind of taught me all these wonderful things. And then here we are today.
That's awesome. And he's incredible. And as you know, he's been on the podcast and he's taught for us and just such a wealth of information. So how cool that was a mentor of yours, because I'm sure that, you know, now you get to carry forward all that information with your practice. And that's really cool.
Yes,
it is. It's really hard to find. I know before we hit record, we were talking about how my kids one has been in 2 rounds of expansion and one has been in 1 round. And now I'm taking them for consults to see if the older one still needs any more. And if the younger one, you know, the younger one needs it. So it's really just a matter of what are we doing next and how are we supporting the airway? But it's so hard to find truly airway centric professionals, because one of the initial people that I did go to when I moved down to Boca did a really great airway assessment, but the treatment plan was a really traditional ortho approach. And I was like, well, that's disappointing. And then they proceeded to tell me that everything that I knew to be true and that I learned and all my colleagues were basically just, a crock of, BS. And I was like, okay, our time here is done. Thank you so much for your time. I was like, wow, well, that was a great evaluation. Unfortunately, we'll be going somewhere else. Or fortunately. But anyways, yeah. So it's so hard to find somebody. And I was driving over an hour down here even just to take my kids because that's how important it was to me to like get this treated. And if anybody knows South Florida traffic, it's just brutal. It is brutal. And coming from DC, it's not much better. But at least up there, I had someone who was like 10 minutes from home and she's a good friend of mine and fell into the Airway space. And I was like, I even said to her the other day, I'm like, I think I just need to come to you for like regular cleanings when I come to visit because I miss your office. It's hard to find this
too, right? Just make the trip back up to DC every
right.
time you got to go visit family and things, and just take everybody with you and go see her.
Exactly, 100. Although we're going up this weekend and she's coming down to Florida, so we're missing each other. But anyways, so yeah, so I love that. I love your story. I love that you decided to kind of step up into this space because, like you said, it is so needed and it's so hard to find providers who get it. So we're going to dive into like all things pediatric obstructive sleep apnea today, and sleep disordered breathing and all of that fun stuff. But I know we were talking about this system, right? This pediatric obstructive sleep apnea system that you all, I guess, are using. And so I'd love for you to speak about what that is and share with our listeners because I think they're going to be excited to hear about this.
Yeah, so it was very exciting. It was introduced to us, I want to say about 2 years ago. So it's a system that comes out of Italy. So Dr. Alessandro Carafiello, he was trained kind of how I think we're all starting to learn how to train ourselves, where it's a full body dynamic of things. It's not just the teeth and the maxilla and the mandible. So he was trained, not only to evaluate the dentition because he's an orthodontist there, but he was also trained as an MD. So he was trained to evaluate posture. He was trained to evaluate breathing. He was trained to evaluate kind of everything. And so in that training and working with the osteopathy doctors and things that he was working with, he came to realize there's just so much limitation to what we do orthodontically. We're just kind of focusing on these mechanical forces. We're strictly focusing on dentoalveolar forces. And so he came up with this system called the Nuvola system, whereby we can basically merge the constant orthodontic forces, those light forces that we're getting, and using it with a clear aligner system, actually. So some adaptations that he has in there, which I'll talk about with his aligner system, it's the similarity it has to other clear aligner systems is that it's clear, but basically the mechanisms by which it's made is completely different. Because what we're trying to do with this in the use of this, what we call freedom appliance, it's kind of similar to things like MyoBrace, right? So it's this prefabricated myofunctional appliance, but these clear aligners and this PMA or this myofunctional appliance are made to work together. And the way that they are made to work together and what they're attempting to do is essentially unraveling the entire cranial base. Because again, I know, as your listeners and your audience and yourself understand, is the bones of the skull are many, right? And when we're moving one single bone, we're obviously going to be affecting other bones, other sutures, right? Other areas of the skull. So it's how do we adapt our treatment beyond just looking at the teeth and the dentoalveolar forces, but how do we completely three-dimensionally unravel and basically establish normalcy or a lack of dysfunction in the entire cranial base? And so with that, kind of also promoting all these great cyclical forces essentially that we see, right? The cyclical forces of mastication, the cyclical forces of breathing, promoting proper respiration, which we know is only through the nose, right? Not through the mouth. And then how do we work with these myofunctional components, the muscles? And so it's the combination and the union of these two things together where we get this truly functional, dynamic orthodontic system that can be used in kids as young as 4, really is where they indicate that for, which is fantastic because again, we're getting entire proper function from a whole three-dimensional perspective, as opposed to just where are the teeth in space and do we have the proper measurement, from molar to molar. So it's just looking at all the dynamics of it.
I love that. So you mentioned something about MyoBrace, but this is different. Like this is very different than MyoBrace. So can you just clarify that for our listeners? Like what are the major differences between something like a myo brace or a healthy start or tooth pillow or any one of those kind of appliances versus Nuvola?
This Freedom Appliance. Yeah. So when we kind of look at the major differences of this, so when we look at this, and I know again we were talking about the Myo brace and Healthy Start and some of these prefabricated myofunctional appliances that we see, the real big difference in this is it is meant to be used with the clear functional aligners. So when we look at the aligners themselves, and again, we'll include pictures for everybody so you can see kind of the differences and how they would differ versus any other aligner system. Because I have had, myofunctional therapists kind of say, well, can I just use like Invisalign with like a myo brace, right? Isn't that the same idea? And when you look at the nuances of this system itself, not really, because the entire purpose of this is to stimulate these cranial sutures and allow deformation of the palate and the skull and all these sorts of things. So when you look at the aligners, I'll start with there first, even though I know your question was about looking at the PMA or the myofunctional appliance first. But when you look at the aligners themselves, one of the first things we see is that we have these palatal reinforcement areas. So versus traditional aligners, where obviously the plastic is going to stop along the borders of the teeth, in these Nuvola aligners or these Freedom Pro aligners, we're actually going to have some reinforcement areas essentially along the palate, so along that lingual surface. So again, as I send you a picture, you'll see you have them along the lingual surface, essentially around the premolars, first molar area, where it's going to be some thicker and it's going to cover a little bit more of the palate, right? We obviously don't want to cover too much of the palate because we're trying to foster proper tongue positioning, right? Proper functionality there. So we don't want to take up a bunch of space on the palate. So that's number one thing that we're going to see on these clear aligners themselves. The second thing that we're going to see is they have these lingual pins that are going to sit directly sort of around that incisive papilla area. Now, these lingual pins are going to work with this myofunctional appliance in order to stimulate the cranial bones, but obviously also, as we've seen in some of these other myofunctional appliances, while either the kids or adults are wearing them during the daytime, it is going to foster that sort of proprioceptive sense to draw the tongue up to the roof of the mouth. So as they're wearing these things and they have these constant orthodontic forces all throughout the daytime, we're kind of getting some more of this proprioceptive feedback. For about 30 minutes during the day, they need to clench on this myofunctional appliance. And so when we look at the myofunctional appliance and how it works with that, right? We have the upper lip shield, right? Like you would see similarly to a lot of these things to stimulate the muscles, right? Orbicularis oris for proper lip closure so that we can get proper nasal breathing. But we also have this lingual ramp that actually pushes up against those pins that were on the clear aligner system. So they work together, right? So as you're masticating and basically contracting on this myofunctional appliance, it's pushing up against this clear aligner, and that's pushing on those palatal suture areas, causing deformation along those clear aligners so that we're stimulating, right, not only the mid-palatal suture, but all the sutures on the maxilla, because there's more than osingular suture along the maxilla that we need to address, okay? Mm-hmm. The other thing that we see is as we're having this masticatory force and we're chewing on this myofunctional appliance, it's pushing up against those pins on the maxilla. That is actually going to kind of work against the apices of the teeth. And the real magic of this is by pushing up there, we're actually using that anterior nasal spine of the maxilla to push up against the vomer. And now we're using the vomer as a piston to essentially translate that force to the sphenoid bone, the occipital bone. So now we're getting inclusion of the entire craniofacial complex, as opposed to just, the maxilla or the mandible. So by, again, that's reinforced areas, those lingual pins, along with this myofunctional appliance, which is specially made to, again, sit against those pins and push against those reinforcement areas. That's where we're getting this entire unraveling, this three-dimensional unraveling of all those cranial bones, ergo correcting the malocclusions kind of at the source. Because when you can look a lot of these source of these malocclusions, right, it's not just, we know it's the breathing and we know airway and things like that, but that creates cranial dysfunctions and that creates cranial distortions as well. And so we got to correct those as well as just kind of moving the teeth by these dentoalveolar and mechanical forces.
I'm like sitting here just picturing all of it. I'm like, this sounds really cool because I feel like, like having had my kids in expansion, having done adult expansion myself after traditional ortho and expansion as a kid, having worked with many patients in expansion. I haven't seen anything like this. Now I've seen people in these orthodontic appliances. I've seen
Mhm.
people in clear aligners with the purpose of expansion, especially like younger kiddos. But to see like the concept of them together to achieve what you're explaining is incredible, because we know that sometimes there are appliances that are created that are out there that are supposed to accomplish something similar, and I think it varies as to whether or not we can actually accomplish that. So to see these two working together is fascinating to me,
Yes.
especially because, again, just having had my kids go through some airway expansion, I'm over here going like, I wonder what would have happened if we had combined these two types of appliances, or like use the Nuvola, where they have the clear aligners, but we also then have that orthodontic appliance in combo. So very, very cool and
Yeah.
exciting. And I know you guys have the article that's coming out soon. So are you able to share like what your findings are, or what the general discussion is around this in the article, or does that have to wait till it's published?
No, so I mean, I'll give you the gist. So the general article, what we were attempting to do at this initial kind of phase of things is really introduce the system. So again, it kind of dives a little bit deeper than I just did in that quick kind of elevator pitch of kind of what we were telling you there, but it dives a little bit deeper into the biomechanics of it. So again, so we can kind of see what's working. We look at some of the comorbidities that we see between pediatric OSA and TMD and pain, and as we were talking about, right, what do we see in these kids with OSA that's going unrecognized, undiagnosed, and untreated, right? We see increases in, the ADHD, right?
Right.
Or even autism spectrum disorder. We see kids that are suffering from depression and anxiety, and it's not because of anything else, but the fact that they're not sleeping. So even when you look at what a lot of psychiatrists and psychologists are telling, these days, is we have to be evaluating the sleep. We have to be evaluating these kiddos' sleeps, because we're unfortunately putting them on all these medications and things that we could likely do away with if we were just properly evaluating their sleep and some of these other things, right? So we do dive a bit into that, and we look at a lot of the research that kind of backs up that, not just from the dental literature, but from medical literature, psychiatric literature, all across the board. And then we kind of finish it up diving specifically into pediatrics. So how can the pediatric population benefit from this? And what are the future advances that we can do in treating pediatric OSA? So this is really kind of an introduction to this for everybody, so everybody can start to learn about this system. I will say as well that Dr. Carafiello was actually in Philadelphia with us. So he was actually coming and giving us all the ins and outs and that really, really in-depth view for us in Philadelphia. And if people are interested in this, like if you are interested in this, you can actually buy the recording of the course. And so it was live streamed. And so if you really wanted to get into the science of that, you can actually do it at the tmjtherapycenter.com. But, we kind of want to take this further and, test our kiddos, right? So the kids with the diagnosis of pediatric OSA, and when we utilize this system, how quickly can we see resolution of their obstructive sleeping? Where can we look as far as the dentofacial kind of anomalies being addressed in a lot of different things that we hope to achieve through time, but really just kind of introducing this because it is such a unique system. And we've been fortunate enough to use it for about the past year and a half, 2 years, and on kids, as young as 4, and adults, of course, as well. And we're seeing these dramatic, amazing results with everybody. So we got to get this out there because it's so much more than, teeth, right? So much more
Right.
than just teeth. Mm-hmm.
Yeah. So what are the ages? Like how young can a child use this? And you mentioned adults, so this obviously can go through adulthood use as well.
Yep. So even kids as young as 4. So with the Sprint palatal expander that they have, which is a double palatal arch bar that is in the system, they have indications for use for kids as young as 4 years old. Now,
Awesome.
as well as I do, a lot of that does depend on compliance with the kiddo. So every person is, different, and every kiddo is going to be different. And so some 4-year-olds may be indicated for that and some may not, just depending on how compliance comes with them. But we can actually see it at these very, very young ages, right? So we don't have to wait till these kids are 6, 7, 8 years old to start with these things.
Amazing. And then just what is your opinion on myofunctional therapy and when to start that? Because when children are in an appliance, and I always like to ask everybody this question, because I think people have varying opinions and differences here, but for a child who, for example, comes to my practice and they get assessed and we're like, we really don't have enough room for the tongue to live up in the palate yet. So we can start working on some things in the myofunctional therapy space, but we truly can't work at perfecting oral rest posture yet, assuming they can breathe through their nose. If the palate is too high, too narrow, and so on and so forth. So do you have any thoughts, opinions, on myofunctional therapy and when to take a break or when that plays in? And, do we allow for expansion first before we then work towards the tongue coming to the roof of the mouth? Do we expect that might happen with this appliance because it's the combination of the myo appliance with the clear aligners? And, would love to hear your thought on that.
Expansion. Yeah, I mean, I think we have a similar thought process, right? Obviously, for me, as a dentist, and I know there's some dentists that do myofunctional therapy. For me personally, in my office, I do choose to work with a myofunctional therapist who is completely separate. I am a firm believer that we kind of all have our little areas of expertise and specialization. And, my myofunctional therapist can see things that my eyes would never see, that we're never really trained to see. So she can see all these dysfunctions that to me, I'm like, oh, wow, that's incredible. I'm so like impressed and amazed with my myofunctional therapist all the time. But, to your point, yes, sometimes there is only as far as you can go. So typically I do defer to my myofunctional therapist, make an assessment for me. Please let me know what you see. Let's at least see what we can do to get something started, right? At least just trying to foster some better nasal breathing to start, if that's the only thing that we can do until we can get some expansion, until we can get release of the tethered oral tissues, until we can kind of work down this whole cascade of things. Maybe we just are at a standstill at some point in time. And if that's the case, that's okay. At least we're working. We know what our end goal is. And that, I think, is the important thing is, yes, these things might take a little bit more time for certain patients and certain populations. Regardless, we're going to at least try and do something to get started. And then, we'll eventually get to point B. We will eventually get there. But sometimes some people just have extra steps they need to take in between. So, I do agree with that. I do agree with everything you said. I think it's great to get properly evaluated, to get assessed, to understand where we're at, what our limitations are, and then work to those limitations until we can get that growth that we need.
Love that. Love that. Now, another thing that you mentioned too was all these children, the behaviors that we sometimes see, or these diagnoses that they often walk around with without having a proper assessment. And I'm really excited because, and I'm sure you've seen this as a dentist, but the AAPD is now actually acknowledging, I think there was this article that came out that's flying all over social media this past week. They're recognizing that airway health actually impacts our oral health in pediatrics. And so we're like, oh, what do you know? The things we've been screaming from the rooftops for years now. Yes. And so finally, I think they're officially stating things like airway dysfunction affects jaw growth and facial development. We're like, well, yes, thank you. Thank you for telling us what we know. Again, can we? So anyways, they had a whole bunch of other things like mouth breathing, snoring, and sleep issues should not be ignored. And myofunctional therapy supports proper oral function and long-term health. And, pediatric dentists should be screening for this and all that fun stuff. So I'm just curious, because obviously you already do all of these things, but do you feel like we might be headed towards a shift in the pediatric dentistry world? Will there be more of a push for like all pediatric dentists to really take pause and at least screen for airway issues, even if they're not the ones who may be fully assessing or treating them? Like any thoughts on that?
I do. And to be honest, and I'm sure you noticed it as well, is over the last few years, we really have seen a transition or a switch from people with sort of that very stringent black and white, like, no, there's no room and stop trying to practice medicine. You're a dentist, and that whole, thing that happens, there, a lot of things we could talk about in that vein of things. But I think I've seen a gentle transition over the years. I've even seen a transition in, people in my area. So pediatric dentists and dentists in my area, I have the pleasure of actually educating with Dr. Omos. And so that's another part of what I get to do. So I do a lot of study clubs locally and, these sorts of things. And I'm seeing so many more pediatric, not just dentists, but even physicians and doctors and ENTs really gravitating to the work that we can do. We have a pediatric sleep doctor who works with us in our office, which is amazing because, again, it's not this siloed off like us versus them mentality anymore, but it's how do we all support and nurture and grow with each other for the benefit of our patients, right? So that's really where the mindset shift has to come in, is this is not a turf war. This is not sleep doctors versus dental sleep doctors and, all these other things, but it's how do we put the person first? How do we put that, aspect of it all first? And so I do think, and to be honest with you, according to the ADA, pediatric dentists and dentists should be have been screening for airway disorders as far back as 2017, if you look at the policy statement that they made. So, there was a policy in place that we should all be screening. And if we don't want to treat, that's fine, but at least screening, evaluating, and referring them as is necessary. But all of this research and all these things that come out just give so much more, give so much virtue to our cause, right? So give so much more presence to what we've been kind of out here and trying to do and teach and educate patients on. Because also, as it's heart-wrenching when you tell a parent something or you talk to a patient about something and they're like, well, I went to my pediatrician and they said that's not true. And so, not just with pediatric dentists, but just even pediatricians, just understanding this relationship so that we're not butting heads and we're all on the same page.
100%. I mean, this is something I was just giving a pediatric feeding screening training to a bunch of SLPs and OTs last week. I do this like free training a couple times a year. And on the last day, I always give them like a bonus training. And it's all about how do we actually connect, because we talk a lot about tethered oral tissues and high narrow palates, because as feeding therapists, we need to be looking inside the mouth. Hello. No one's ever really taught them that before, but we're going to do that now. It's not like we work in the mouth every day or anything, but hey. So on my last day, I do this like free bonus training on how do we connect the professionals who get it in our area? How do we find these people? And I actually open their eyes to the fact that more dentists are getting into the airway space. It's still hard to find them, but you might be able to. And like, here's how we can search for them online. Because I've personally found that dentists, pediatric and just, family dentists, adult, geriatric even, they really, I'm noticing that you all are more flexible in your interest even to learn. And my friend, my colleague who I took my kids to, who started their expansion journeys and did my adult expansion up in Maryland, she and I remember we sat at a CEU event together and learned about tethered oral tissues and really dove deeper into it. And that was not necessarily, it was maybe towards the beginning of my journey 8 or so years ago. And I think it was maybe towards the beginning of her TOTS journey too. And it was just powerful. It was so cool to sit there with a colleague who's in a completely different, space and be able to have these conversations and learn together. And then we started a study club and we started just, reading different airway books. And there's some individuals in our area who actually wrote books who were able to come and speak to us. And then we started to build and build. And finally, we had like 10 different types of professionals sitting around my kitchen table. We're all passing around one singular case, looking at it. And it was so mind-blowing, right? At that point in my career to go, we all are looking at the same case, but with our lens on, right? With the different perspectives that we all come to this table with, we're all seeing something different.
Yeah.
And how cool and powerful and crazy at the same time is it that we can all see the same case, the same photo, the same videos, the same medical history, and all take a very different approach to the patient sitting in front of us. And it just really opened my eyes to exactly what you were saying, that we can't treat in silos. We really need to, that's not like one in, one out as far as professionals go. It's like we all need to be sitting around a table together. Not that modern medicine really allows for that. Thank you, traditional, modern insurance. But, a lot of us have become private pay, or we've been private pay because it allows us to do this. And so we've really worked very hard to create that collaborative model to the extent that we can. And remember, we have a patient, a human sitting in front of us, and they're a whole being, and our entire body works together from the tip of our tongue to the tip of our toes and everything in between, and it's just like, we've got to stop treating in silos. Like you were talking about, we really got to take this holistic, whole patient approach. So I love that you brought that up, because I think that that's always been a big theme on my podcast. And I'm just hearing more and more people talk about that now. And I'm like, oh yes, please. Can we continue to move in that direction? Because it really just benefits the patient.
Yeah. Yeah. And that comprehensive team-based approach, that's key, right? So, and I know it can be frustrating. So I know some of you, if you're just getting started out on your journey, you're frustrated because you're like, I can't find the ENT and I can't find the sleep doc and I can't find these people that I want to work with. And yes, sometimes it can be unbelievably frustrating because you do want to move this forward and you want to have that team and you want to have that collaboration. And unfortunately, you're just not getting those people, but just don't give up, because you will find that team of people. I promise you, you will find that team of people. But, just like Hallie said too, it's getting out there and it's going to these CEUs and meeting different people and getting different vantage points. And that way we can hear what they're saying to us too. So yeah, I love what you said. It's so much of a collaboration, and we have to think of it as, how do we all work together?
Yeah. Because I know at the end of the day, the most frustrating thing, like you said, is educating a patient. They're all ready to go. They go to the next provider, and that provider is like, "You're fine," or "Nope, that's not true," or and you're just like, "Oh, okay, here we go again."
Yeah.
Just unraveled all the work that we did.
Right.
Fantastic. Thank you,
X that
pediatrician,
one
or
off the
whoever.
list.
Yeah, right. Exactly.
Yes,
Exactly.
pretty much.
Exactly. So you mentioned the screenings, and that that basically dentists, I guess since 2017, should be doing these airway screenings. Anyways, it's great that the AAP, PD finally got on board with, the general, I guess, the general dentist organization that had put out.
AZA. Mm-hmm.
Yeah,
Yep.
ADA, thank you. I was like, it's escaping me at the moment, but I know what it is. So what should a screening look like when a dentist is screening for an airway issue, or trying to determine if further assessments necessary?
And so that should be pretty in depth, right? So when we're screening, we want a pretty rich health history when they come in. So there's things we want to see if we're specifically talking about, pediatric population. Besides just kind of chief complaints, do we notice any mouth breathing, right? Do we notice any snoring? Do we notice any kind of labored breathing, drooling, at nighttime? Do we notice frequent tossing and turning, sweating, nighttime urination, wetting the bed, all these sorts of symptoms that we can see in kids. Any irritability, right? Any hyperactivity. So these are all symptoms that we can see, and that should all be on our health history form. So parents fill all that out beforehand, all the things that they're kind of assessing need addressed. But as well, besides that screening, then we're going to do physical exams for them as well. I should go back and say on the health history, particularly if we are screening for airway, a BEARS screening is a validated questionnaire. And then, of course, the PSQ, which is the Pediatric Sleep Questionnaire. So those should be included on there also. So we want to go through main symptoms that we would see on kids, main signs that we would see on kids, and kind of have all that information ready to go prior to them, walking in the door, or at least prior to us going into the room and starting to kind of just look at their mouth and their jaws. We want to know what has been experienced prior to this point. What is the parent's experience prior to this point? Because again, because you had children with these same issues, it's not just what the child has experienced, it's the agony that the parent is experiencing as well. When you are so desperately saying, somebody please hear me, there is something wrong with my child, and yet nobody is addressing it, nobody's paying attention yet, they'll grow out of it. These sorts of things. Okay, so it's what is everybody kind of dealing with, and what have we all experienced up to this point? And then, of course, when you're addressing it physically, so when, the child or adult, depending, but if we're talking about kids specifically in this situation, when they're in their office, what are we looking at? We want to look at, is the child developing? Do they have maxillomandibular growth in the way in which we would anticipate? So with children, as you've mentioned, we don't want this narrow, high vaulted palate. If you just even look at the teeth, does the kid have primate space? Do they have those big old large gaps between their teeth? Parents get so excited because they don't know. And they're like, my kid's teeth are so straight and they're touching. And I'm like, that's so bad though. We don't want that. I want this big gap, kind of gawky looking children. That's what we want, right? That's what they're supposed to look like.
Yes.
All right. So, assessing the proper development and growth. For us as well, besides just airway, we have to remember that airway isn't just the oropharyngeal airway. It's your nasal airway too. When we're assessing the upper part of the airway, it's your nasal airway as well as your oral airway. So when you're looking at the oral airway, let's look at the tongue, right? Because the tongue is going to give us a lot of clues. Do we see that the tongue is spilling out over the occlusal surfaces? Is it retracting into the airway on opening? Do we notice any tethered tissues? Look in the back of the throat. What do the tonsils look like? Okay. Do we see enlargement of tonsillar tissue? Are we grade 1, 2, 3, or are we completely obstructing at a grade 4? Does the uvula look like it's been shaken around from all the snoring the kid has done? Is it large and swollen? So all these things we can assess in the physical exam. But even so, kind of identifying, is the kid the whole time, like they can't catch a breath through their nose. And so then we have to say, okay, is there something we can do to address the nasal airway as well? Depending on the age of the kid too, and depending on some of their symptoms, CBCT imaging might be necessary, where which we can actually look at some of those nasal tissues. We can look in the throat, we can evaluate the oropharynx, kind of see dimensionally what things look like, and, as well as addressing a lot of those concerns there. And then, is there a need for further assessment from a sleep doctor, a pediatric sleep doctor, from what we've seen? So those are kind of, in short, the things that we would mainly be looking for.
Awesome. And I was going to ask you next what kind of imaging you recommend or what you do, but you mentioned the CBCT. So is that the primary imaging that you'll do? And did you do that in office?
Yes. So we do have a CBCT machine in office, and we do it. So we're able to do that kind of right away. With that, and when we're treating pediatric sleep apnea, we know that getting both vertical dimension as well as AP dimension, so anterior positioning also, you can actually evaluate kind of before and after how well of a job you're doing at sort of opening that airway, and just using some metrics that we can get through some modeling and some software.
Awesome. Love that. My kids have had, well, Mia's had one CBCT. Lily's had two at this point at different phases of her expansion journey. And I'm quite certain we'll probably have a new updated one in about 3 weeks when we go for our next consult with the new Airway ortho that we're going to go see. But it's really incredible. It's very cool. And I kind of geek out over those reports that come back with them, because it's very cool to see things that I wasn't even aware of. Like when my now 9-year-old was 4 and we did her first CBCT, I had no idea that her sinuses were almost completely obstructed. In addition, I mean, I knew her tonsils were big, and I kind of figured that her adenoids were big too, based on all the symptoms and everything, everything that I could see. But when that came back and I saw her sinuses and I saw just how congested she was and how swollen she was through her nasal airway, I was mind blown. And then to see a year later, after some, expansion at age 4, about a year later at age 5, when we did a follow-up, and this is a very holistic, crunchy kind of dentist, and she was like, we really don't have to do the CBCT. I was like, no, I need you to do it, because for learning purposes, I'm like, it's okay. It's a quick snapshot. I'm not worried about it. And because they're very cautious of like radiation and all that. And she's like, I know it's not a lot and it's just a little. She's like, but I have to say this. And I'm like, it's fine. It's fine. So we did it, and her sinuses were clear. And her nasal airway was beautiful and clear. And her adenoids were a healthy level. And her tonsils, you could see through the mouth, her tonsils were a healthy level. And on the CBCT, it's just like to see the difference night and day between, where she was at age 4 and age 5. I was like, okay, I'm sold. What else do we need to do anything else? Like, she looks so healthy now. And it was really incredible to see how much her health benefited from that as well, because she's definitely my more hyper kiddo, bouncy off the walls kind of kiddo. And I have absolutely no doubt, because I was diagnosed around probably age 5 with ADHD. So I haven't absolutely, and my mother refused to medicate me. Thank you, Mom. But I was more like irritable and distractible and not so hyper and destructive in a classroom or anything. But anyways, with my now 9-year-old, I can see how this would have gone very, very differently in the school setting had we not gotten in there and done that. Because she was a good listener in school, and she was calm and cool and collected and everything. But when the pandemic happened and everything switched to virtual, which she was pre-K going into kindergarten, in pre-K, it was like she was sitting in a chair, and after 5 minutes, she was like, I'm bored, and just like falling out of the chair. And I was like, and we're going to do kindergarten for 23 hours a week? Like, no. And I ended up homeschooling her, because I just felt like this is ridiculous for a 5-year-old, but that's neither here nor there. It was really amazing just to see how she changed over that year, because this was all happening at the same time. And even her attention level and her ability to sit for 4 hours and do work on a Sunday so we could take most of the week off from our homeschool curriculum at age 5. I was like, I am absolutely floored. So it was very cool to see that. And I think that before and after CBCT was just, I use that all the time. And I even show people the difference between her palate, just the photos of her palate when she started and when she finished that first round of ortho. Absolutely incredible.
Yeah. And like, and especially, in your field, right? So how can we do a proper assessment and proper myofunctional therapy if the person can't breathe through their nose, And so looking at that and understanding that, and like you said, even just seeing some of that tissue hypertrophy or sinus congestion, but even in like adults, I can't tell you how much bony obstruction there is, deviated septums and concha bullosa and all these other things. And yeah, right. And
That
so
was
it's
me. Yeah.
right. It's like
Yeah.
we gotta know what we're standing up against too.
Yeah.
So imaging is very crucial as well.
Yeah. I mean, and it's interesting you bring that up because for me personally, I mean, I'd had traditional expansion and braces and my teeth were beautifully straight and I had permanent, wire retainers behind my upper and lower teeth. And I think when I turned 30, I went to my dentist and I was like, you said these were going to fall off in a couple of years. They have been on for like 15. So can we take them off? Or he took them off and my teeth started to shift.
Mm-hmm.
And I was like, what is happening? Okay, this is almost 10 years ago now. And over the course of several years, I noticed my teeth they were crowded. And anyways, so I then knew what I knew and ended up getting adult expansion. But after the fact, went to an ENT down here in Boca. She sent me right down the hall for a CBCT in my consult and pulled it back up on the screen when I came back down the hallway. And we had this whole conversation. I had a deviated septum, but it was like in the back left. So you couldn't really see it on my nose. Like I had gotten a little bump in pregnancy because I was swollen and my airways was definitely impacted. But I also had enlarged turbinates. I had enlarged nasal swell bodies, which I had never heard of before.
Yeah.
And so we fixed all of that. But it was amazing to me because I also dropped like 15 pounds after that surgery when I could breathe again.
Yeah.
And how long had I been trying to get that baby weight off? I mean, it just wouldn't come off because my body was clearly, I'd had sleep studies, no OSA, maybe UARS, which was still so new that like most people don't recognize upper airway restrictive syndrome, right? So I was really more so presenting with that, and everyone's like, "You're fine," and I go to the ENT here finally, and she's like, "You're not fine," and I was just like, "Oh, thank you so much." But it was really amazing because even being in this space, I still didn't realize how much life I was missing out on, and how much more energized I could feel, how much better I could feel, really, until after the procedure, which was just absolutely mind-blowing to me because I get a lot of adults who go through expansion, who go through myo, who sometimes have to have nasal surgery or whatever the case may be. And I hear the same thing. I had no idea what I was missing out on.
Yeah, because if your nasal obstruction is a function of your dysfunctional growing, right? So not forming properly when you were a kid, that's all you know. You went through your whole entire life with that. So for you, that was normal breathing. Yeah. And that's what you have to explain to, patients too. It's like, well, they're like, I feel like I breathe fine. I was like, because that's all you know. You know this very limited ability to flow air in and out of your nose. Like you don't know what real full functional breathing feels like. And, they get it done and they're like, oh my, I didn't even know that. I was like, yeah, that's air. That's oxygen.
Right. It's wild.
It's like this whole new phenomenon. Like, what is that? Oh, it's called breathing.
My body just was like, oh, we don't have to hold on to all this inflammation anymore. You sleep now and you get actual restful sleep. I mean, I was sleeping, but clearly I was not getting actual restorative, like restful repair. My body was not able to repair itself during that sleep. I think when I had the raw data on my home sleep test read, I was basically waking up to a certain alertness level every single time my body tried to go into REM. So it was never actually getting into REM, which is just so destructive for your body and your brain even. And so I'm glad I figured it out when I did, but it really opened my eyes, even beyond what I already knew as a professional, which was just incredible. So I'm very grateful for the whole process, but really makes you also just recognize how important it is to address this as young as we possibly can.
Yeah, absolutely. Because you'll start to see some septal deviations in kids, little ones, it's just because, again, if we're growing and if the nasal volume isn't where it needs to be, we're just going to kind of, and things are just going to shift over. So if we can address these things ASAP, so much better. And again, to your point too, because you were kind of saying, talking about, everyone's just kind of like, it's fine, you're fine, right? It's the whole like, you're just a new mom, it's fine. You're just like that whole
You're
situation.
Tired. That's normal. Yeah.
Yeah, just get over it, quit whining. So, you know what I mean? But I'm happy and I'm grateful for you and for whoever your provider was, your ENT, that they didn't just kind of take it at face value of, oh, it's fine. Just, toughen up, buttercup, and, deal with
Yeah.
it. And they did properly evaluate you. And that's why we have to do these complete evaluations. We can't just make any assumptions. We need raw objective data. We can't just go on some of these subjective things.
Yeah, it was very exciting. And she also happens to be a double board certified facial plastic surgeon as well as an ENT. So I was like, so while we're in there, can you get rid of the bump? And I was like, I don't really need you to like reconstruct the whole thing, but can we just make it look like straight? And she was like, yeah, okay. I was like, we're going under anyways. Meanwhile, she was like, I don't have to put you all the way under. She's like, she does like closed, surgeries and open. And so she's like, it'll be an open one. And then you'll really have to be under general and it'll be longer. I was like, that's fine. So we did the whole shebang. And I love it. And I now look at my nose as something that I love and it feels like it's very healthy. This like center of my face feels very healthy. Whereas before I could look at my nose and I just felt like this is the cause of all of my problems.
There's something not right there.
Something is off here. Okay. So the last thing I wanted to ask you about, or maybe just ask you to kind of touch on is, I think a lot of times parents and even providers sometimes hear things like, oh, the child has obstructive sleep apnea, and we treat that as an emergent kind of thing. But then we hear, oh, the child just has mild sleep disordered breathing or moderate sleep disordered breathing, as if it's not important or it can be kind of brushed under the rug. I've learned that that's just as equally important to address.
Mm-hmm.
Can you just speak to that? I mean, how do you educate on that? And what are some things that people should really be aware of when it comes to just even mild sleep disordered breathing?
Right. And so that is, when we talk about things that can frustrate one, provider, that is something that really significantly frustrates me is, well, it's not that bad. And, when you look at the literature and when you look at the research and when you look at the more up-to-date research, when we're talking about sleep apnea, number one, the way in which we score it, even Dr. Guilleminault, has stated, I never meant for it to be that simplistic. I never meant for it to be just a number and you look at the number and you say it's normal or abnormal or mild or moderate or severe. We're always meant to look at the data within that study as well. Like we can't just go, oh, AHI, an adult is 5 or less, or in a kid it's 1 or less, and you're normal, right? Even if everything comes back normal, do we see hypercapnia? Do we see hypoxia? Okay. And even if we don't see significant amounts of hypoxia, do we see frequent arousals at nighttime? Because when you look at all the destructive and negative downstream consequences of untreated sleep apnea in both adults and kids, like, the fact that your brain can shrink, right? You see hypertrophic changes to the gray matter in your brain, increased incidence of type 2 diabetes, cardiovascular risks, all of these things. When you look at the disease mechanisms there, the disease mechanism is not strictly hypoxia. So it's not just how much did you obstruct and how much did you desaturate in your oxygen levels. The other facet of that is frequent arousals, right? So frequent awakenings. So it's a combination of the hypoxia and the frequent arousals that are happening. And so we can't really just go, oh, well, the numbers stated that it's mild in nature, so it's okay. Maybe you can treat it. Maybe you don't have to. And yet the patient is still walking around symptomatic, basically saying, I feel like garbage all day, every day, and I don't feel my best. And I am so much brain fog and I have so much fatigue and I can barely function, right? And we can't go, oh, well, the number value said it was fine. Objective data is good, but we have to be able to, evaluate all of the objective data. So because it's not just that number, it's not just that AHI. And again, when you look at a lot of the research that's coming out, it's saying it goes so far beyond just the AHI, right? Looking at the CO2, looking at the O2 DSATs, but also just looking at how many times somebody's arousing or awakening at nighttime, that's going to cause disease as well. It's not just how low your oxygen drops and how often it happens, but not getting into those deep restorative sleep stages, that fragmented sleep, puts you almost at a similar risk for having all of these consequences as well. So we can't just look at it like one single value. And I see it way too much. And that's why when somebody comes to me and they're like, well, I had a sleep study and my doctor said it's normal, I was like, can I still please see it, please?
Can you send me the raw data, please?
Because I'm just gonna look at a few different things, and you see that, it's yeah, okay, fine, your AHI was 5 or less, and yes, it is mild, but there's so many other things that contribute to good sleep. Just like you said, even, for you, that UARS and just the inability to breathe properly through your nose, look what a difference it made, right? Yeah. Even though you didn't have apnea, so to speak, you still had a form of sleep disordered breathing. You still lacked the ability to breathe properly and functionally through your nose. And look what a difference it made.
Yeah. Well, and thankfully I had access to somebody who does home sleep tests where he actually reads the raw data. And, I knew what I was getting into when I did it because I figured, well, he knows how to read all the data that's going to come through, like everything you were talking about, right? He went through it with me afterwards and was like, this is exactly what's happening while you're sleeping. This is the position you're lying in when it happens. This is how this happens. And I was like, this is so cool. But also no other doctor ever goes over this with you, right? I mean, I'm sure there's other ones out there who do read the raw data, but it just seems so hard to find that sleep doctor. So anyways, yeah, it's so critical. So thank you for speaking to that because, I know I've said it before too, that I know Gimeno never really intended for the scale to be used in the way that insurance really uses it,
Right.
which kind of dictates how some doctors will then approach it. And it's like the same thing in the tongue tie world. Like I hear all the time, oh, it's just a slight tongue tie. It's just a mild tongue tie. It's just I'm like, either we have tight tethered tissue or we don't. Either it's impacting function or it's not. Yeah. I'm not sure why, it's pretty absolute. And then how we approach it might look different. Maybe we need a release. Maybe we don't. Maybe behavioral interventions are enough without surgical interventions. Maybe they're not, right? It's going to vary from patient to patient, but it's like something needs to happen. Something needs to be done. You were here for a reason in the first place. Obviously, right. There's probably a functional impact, right? So it's very fascinating to me that, every time I hear someone go, oh, it's just a slight tie, or, oh, it's just, mild SDB, sleep disordered breathing. I'm like, oh, okay. All right. Well, that's very helpful information. Thank you. Let's have a conversation. Okay.
Yeah. Like you said, obviously somebody's here and they're symptomatic. So there's obviously something going on. And right. This case of mild needs to be addressed.
Yes, totally. Mm-hmm. Amazing. Well, I know we've talked about a lot today. Is there anything else that we didn't cover that you want to speak to before we wrap up?
No, this was fantastic. I really enjoyed kind of coming on here. Like I said, the Nuvola system we're excited about. So I'll definitely send you that when it goes out, but I'll definitely include those pictures and images for you guys because it's just such a revolutionary system. And it's I think, going to change the game for how we can treat, some of these issues and how we can treat some of these palatal constrictions and improper facial growth and development, because we're going to be able to not only do the maxilla and the mandible, but all of the cranium along with it, which is just
that's awesome.
So cool. Mm-hmm.
Yeah, that's so awesome. I worked with a physical therapist whose whole business was like unlocking your body.
Yeah.
And, he's like PRI trained, but also a whole bunch of other types of trainings too. And I told people, I'm like, I feel like he barely put his hands on me when I was in the session, but when I would leave, I feel like I had an entire like full body massage because everything is just like moving and flowing and everything's working together again. And it to the point where like I couldn't even turn my appliance without seeing him halfway through the treatment because I was so locked up, and I would see him and then I could turn the appliance again. And so that also really opened my eyes to, all these cranial sutures, just the sutures throughout our body and how we really need to be flowing and things need to be, not so locked up. So really cool. I'm excited to learn more about this appliance and dive into it a bit more. So thank you for sharing this with us.
Of course. Thank you for having me. I had a great time today, Hallie.
So Kristina, real quick, tell us where anybody can find you. If they're like, I want to see Kristina, I know you're in Ohio, but how do they find you either as a provider or even someone who could speak to a group?
Yeah, so I am in Ohio, but like I said, so I've Doctor almost mentored me, and so I've actually helping him, and I'm taking over as his lead educator for his mini residency series. So awesome. We do teach a mini residency talking about treating comorbid TMD and sleep disorder breathing in both adults and children. So you can find me and information about me there at TMJ Therapy Center, RECENTRE.com. And then also my personal site is clevelandtmjsleep.com. So you can reach out to me there. I am always happy to speak. I love talking and talking about all these things. It brings me tremendous joy to do these things. So you could also reach out to Tiffany. So Tiffany is kind of our director of operations on TMJ International. And so that's Tiffany at tmjtherapycenter.com.
Amazing. Thank you so much.
Thank you.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyoTots airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at HallieBalkin.com or pop over to @HallieBalkin on Instagram to get all the latest updates.